Well, hello there, guys. Welcome to Pediatric Emergency Medicine's Building Blocks webinar. So today we have got a wonderful, wonderful guest. We'll be calling in to Dr. Chris in a little while. Dr. Chris is one of our pediatricians who's currently a fellow in Pediatric Emergency Medicine, right here in Pediatric Emergency Medicine, Malaysia. So let's see if we can give Chris a call and get him on board. Oh, hello. Hi there, Chris. How are you doing, buddy?
Hello. Hi.
Great, great. Good
Thank
to
you
have you
for
on
having
board.
me.
I was kind of telling everyone that we're so excited to be here today. This is one of those things that we've been aiming for a long time, and we've finally got off the road. So I just want to introduce our speaker today. Our speaker today is Dr. Chris. Chris is a pediatrician, right? Who knew pediatricians like emergency medicine? But Chris absolutely loves it. Chris is one of those people who loves the adventure on the road and kind of thinking on his feet. So Chris is kind of one of our first year fellows. Chris has been absolutely amazing. And today, Chris will be talking to you about jaundice in the neonate. Now, Chris, being a pediatrician, he's been on both sides. He's worked the district hospitals, he's worked in clinics, he's been on the side who's giving the referrals and also the side that's kind of taking the referrals as well. So Chris is absolutely the perfect person to kind of tell you guys about this. Chris, want to tell us a little bit about what you're going to be talking about today?
Yes, thank you for having me aboard. Let me share my screen. All right. Yep. And all right. Give me one
And so
second.
while Chris is kind of doing that at the moment, so we want to let you guys know you can ask as many questions as you want. And as you ask questions, you can ask it in the YouTube chats and we will answer them. We'll put them up on screen and we will answer them as we go along. So don't worry, just ask as many questions as you want. The idea is that we're going to build some blocks here, get this tower really high and get the knowledge levels up there. All right, Chris, take it away.
Thank you so much, Kiran, for the introduction. All right. Welcome to the first of our series of webinar, and this will be on neonatal jaundice. So you might be asking why neonatal jaundice. Usually when people present webinar, it will be usually hi-fi things, groundbreaking things. But I think you have been through your fair share of talks on ventilation strategies or strokes or MIs. But when was the last time you actually had a talk on neonatal jaundice? For me personally, it was probably way back when I was a house officer. Neonatal jaundice being our bread and butter is something that we deal with day in and day out. And because we deal with it so often, a lot of people assume that everybody knows everything about it. But that's not always the case, isn't it? And even when we have questions, we have things that we're not sure, we are a bit shy to ask. So the objective of this webinar is to keep everybody on par and also to open a platform for everybody so that you can ask your questions away without feeling shy. So without further ado, let's start this webinar. So we are going to follow the story of baby Amiro, who is currently day 4 of life. He was born term at 39 weeks, good weight, perinatally uneventful, and was discharged at day 2 of life. And day 4 of life, the nurses went over to his house, did a simple check and found out that everything was rather okay. With one slight exception, he was jaundiced, and they noticed that he was jaundiced up to the level of his face. So he was referred to the Klinik Kesihatan on the coming morning. But unfortunately, the next day turned out to be a Saturday. Amiro's mom wasn't in the know that clinics open on Saturday. So where did Amiro's mom bring him to? To the ED. And you were the fortunate MO on that day that was attending to Amiro in the green zone. All right, so let's talk a little bit about neonatal jaundice. Neonatal jaundice is very common. How common? 6 out of 10 term babies are jaundiced. 8 out of 10 pram babies are jaundiced. So more often than not, a newborn baby will be jaundiced. And in medicine, we are always taught to think of common things are common, right? So when you hear hoofbeats, always think of horses and not zebras first. So if you were to make a guess as to what the cause of this jaundice would be, if you make a guess of benign unconjugated hyperbilirubinemia, in other words, physiological jaundice, probably 99 out of 100 times you will be correct. But that is not the objective of it. In the screening of jaundice, what you want to pick out is the zebras among the horses. So our objective here is to differentiate physiological jaundice versus pathological jaundice, conjugated jaundice versus unconjugated jaundice. So back to the story of Amiro. Amiro's mummy is sitting across you on the table and she asks you this question. Kenapa kuning? Dulu abang kakak dia okay je. So why do neonates get physiological jaundice? So it stems back to the physiology of it all. So baby who is jaundice will have increase in production of bilirubin and decrease in elimination of bilirubin. So in an adult patient who comes with you with dengue fever and you look at the hematocrit of 40, that will get you all jumpy and worried already. But in a neonate, the acceptable hematocrit is all the way up to 65. HbF as opposed to HbA in adults also have a shorter lifespan. So all this leads to increased production of bilirubin. On the other hand, this free bilirubin will be passed through the liver. It will be bounded with albumin and in a process called conjugation. However, in neonates, the liver are immature and this conjugation process is not as good as in adults. And also when this bilirubin is produced, it's usually passed out in stool. So our guts are full of natural flora which helps to break down this bilirubin to stercobilin, which gives our poop the natural brown color. But for all these neonates, their gut are relatively sterile. Meconium is sterile, so they don't have this mechanism to get rid of the extra bilirubin. So what happens to it? It gets reabsorbed back in our enterohepatic circulation and gets recycled back in our blood. So this leads to an increase of chance of a child being jaundice. So how can actually we prevent jaundice? Is there actually a way in preventing jaundice? So some mothers will come to you and say things like, I heard that switching over from breastfeeding to formula feeding will reduce jaundice. Is there any truth to this? Well, the answer is yes, but should you ask or advise parents to stop breastfeeding and start on formula feeding? No, you should not. Why so? How do we convince them? So the jaundice that is associated with breastfeeding is usually a very benign jaundice. So they might be jaundice for a little while longer than their counterparts who are formula fed, but it is not dangerous and it's something we just have to monitor. So to deprive them from the benefits of breastfeeding, the nutrition benefits, the immune benefits, just to bring down the number, just to make us feel better, is not warranted. So what about babies who are breastfed? We need to make sure that they are well hydrated, they are not dehydrated. So we need to firstly know what is the normal. So a normal breastfed child should be breastfed for 8 to 12 feedings per day. And how do we know that it's sufficient? So unlike bottle feeding where you can actually measure and see how much goes in, you can't do the same for breastfeeding. So we've got to go with secondary, signs. So if the baby is feeding well, the baby is content after feeding, sleeping after feeding, you've got enough wet diapers in a day, then you can be assured that your feeding is sufficient for this child. And on the other hand, you also have formula-fed babies. And how much should they feed? So it's 1 to 2 ounces every 2 to 3 hours for the first week of life. And then comes the question, should I change formula? Should I change to formula M? Should I change to goat's milk formula? Because my friend said that it reduced the incidence of jaundice. Well, there's no truth to that. all right? And also advocating for changing to a goat's milk formula is actually very dangerous for the child. The sodium contents is way too low. So if the baby is all right with one formula, don't change it just for the sake of jaundice. Stick on with it, make sure they have enough to drink, and that should be adequate for the child. And this one, the last one, is also a very common thing, right? So my baby is a little bit heaty, that's why he is jaundice. So is there any truth to that? So strictly no supplementation of water for children below the age of 6 months old. Okay. There are also other things that might not be detrimental for the baby. It might not bring any good, such like bathing the child in herbs or applying some special water onto the skin. As long as it doesn't bring any harm to the baby, I will permit it, right? Because sometimes it is also very stressful for the parents to not be able to do anything for the child. So as long as it doesn't harm the child, I will usually allow it. So you have a yellow baby in front of you. What are the steps to take? So this would be my approach when I see a baby who is yellow. I'll ask myself a few questions, and at the end of it, I'll decide whether I can send them home or I can admit them. So firstly, is the baby yellow? How long have they been yellow for? How yellow are they? What are their risk factors? And are they otherwise well? And finally, can they go home? So let's take it in turn. Let's start with the first one. Is the baby yellow? So how do we tell if it's a baby is yellow? What did the nurse do? So only one way to do it, using eye power, right? So we look at the baby and we determine, is the baby yellow? So you stop to wonder, for the case of Amirul, how accurate this eyeballing test actually is. So let's take a look. So we are all very familiar with Kramer's rule, right? Kramer's rule, when you see the baby, and if you can actually detect the jaundice visually, then the level would be at least 85 micromoles per liter. And for some reason, this jaundice progresses craniocaudally, means it starts off in the head and progresses all the way till the palms and so. So when the baby is yellow over the head, that corresponds to a serum bilirubin of about 100. At the upper trunk, it's 150. It's below the umbilicus, it's 200. Arms and lower legs, that will be around 250. And once your palms and sole are both yellow, that would be in the vicinity of 300. The caveat to this is that make sure when you examine the baby, ensure that the lighting is adequate. The best would be natural light. So bring this baby over to the window or the door, get the line shine in, and then you can see best lah. But if you don't have that, you don't have a window, just make sure that your light is adequate. So I remember back when we were MO in the first class ward, to make it comfortable for the parents, all the lightings were yellow, and that really drove us up the wall. So bring them to white light and make sure you have adequate lighting. Okay, let's take a look at this paper. This was done in Pennsylvania in the US, where they took 522 term and late preterm newborns. So they got all the nurses to scale these babies using the Kramer's rule and give them a score from 1 to 5. So what did they find? They found that this nurse's assessment of this jaundice extent only moderately correlated with the bilirubin level. And surprisingly, it is similar in both colored and non-colored infants. When these babies are less than 38 weeks, this correlation becomes even weaker. And when the jaundice becomes very high, the accuracy in predicting the serum bilirubin becomes even lower. However, one thing that they found, that when the nurses looked at it and there was no jaundice at all, there was complete absence of jaundice, they were mostly right with a sensitivity of 95%. So what is the kesimpulan that we can take home from this paper? So if you look at the baby and the baby is not jaundice, then highly likely the baby isn't, and it will correlate with the serum bilirubin. However, if the baby appears in any amount of jaundice, then you cannot score based on just your visual assessment, and it warrants objective measurement of the serum bilirubin. So back to Amirul, you are now convinced that Amirul is indeed jaundice. So what do you do next? You have to determine how long have they been yellow for. Any jaundice that appears within the first 24 hours of life is pathological, needs to be worked up, needs to be admitted. So the causes, possible causes for this are hemolysis. They could have an intrauterine infection or even sepsis. And most commonly, they present to you at 2 to 14 days of life. That's the most common presentation. And a lot of times, this is just physiological jaundice, and there might be risk factor which will increase the risk of them being jaundice. Anything beyond 14 days of life for the term babies and beyond 21 days of life or for prem babies would warrant a prolonged jaundice workup. The next question you ask is how yellow are they? So you need some form of objective measurement of their yellowness. And I know of 3 methods to do so. The first one is a transcutaneous bilirubinometer. Second is your capillary, and lastly is your serum bilirubin. So this one over your right is a transcutaneous bilirubinometer, or what we call the TCB. The common brands are Draeger. There are some made in China these days. So how does it work is that there is a knob at the top, at the bottom, that you press onto the baby's skin with a total of 3 times. It will take readings and it will average out these readings and give you a final score. All right. If you read the manual, it tells you that you can measure at 2 points, either the forehead or the mid-sternum. So we would actually prefer the mid-sternum, reason being that your forehead is more likely to be exposed to sun, whereas your sternum would be wrapped up in your baju, so less exposure to sun. However, this TCB may over or underestimate bilirubin concentration, so it should only be used as a screening tool. Any levels more than 200 micromoles will tend to not be accurate, and therefore, if it's more than 200, you need to follow up with a capillary or a serum bilirubin. There are some caveats in the use of this TCB. So if the baby has ever been on phototherapy before, you cannot use it. If the baby is less than 24 hours of life, you can't use it also. And for babies that are less than 35 weeks, for some reason, their dermal layer has a more natural yellowness to it, so it will not be very accurate as well. So you cannot use it for these 3 caveats. But my ED don't have TCB, so what do I do? So that leaves you with either capillary or venous bilirubin. So we all know that venous bilirubin, serum bilirubin would be the gold standard. And if you have it in your center, go for it. But does that mean that there is no role for capillary bilirubin? Not so. So there are venous bilirubin requires a big machinery, expensive cost, whereas on the other hand, capillary is just a small portable machine, readily available, cheaper, and can be made available in much more places. So there is still a role for capillary bilirubin, but if you have the venous one, go for that. So let's compare venous bilirubin and capillary bilirubin. How much difference does it actually make? So there is a paper that was published in Taiwan where they took pad sample for a number of patients, and they plotted on the graph, and it actually shows a linear correlation between capillary and also venous. But in every single reading that they took, the capillary bilirubin was actually was lower than that of the serum bilirubin, with a mean of 1.7 mg per deciliter. And this difference actually becomes more significant if it passes 15 mg per deciliter as compared to 10 mg per deciliter. So at 10 mg per deciliter, this differences was only in the range of 0.17 to 2.09 mg per deciliter. But when it is 15, this increased significantly from 1.29 mg per deciliter to 2.77 mg per deciliter, right? So the take-home message to this is that you can still use capillary bilirubin, but bear in mind that it will be slightly lower than that of the venous bilirubin. And at very high levels, this difference might be even more significant. So you might want to follow them up with a total serum bilirubin or a lower threshold to refer those with capillary bilirubin. Next question is, what are their risk factors and are they otherwise well? So there is only one way to actually do this, and there is no shortcut, and that would be through thorough history and physical examination. So what history to ask, what to examine for? So let's take a look at the history. First, you want to know the day of onset of jaundice to distinguish between pathological early jaundice, physiological jaundice, or prolonged jaundice. Next, you also want to know if there's any antenatal factors that might increase the risk of jaundice. So infant of diabetic mothers, whether there's torches that is positive in this current pregnancy or previous pregnancies. Maternal blood group. So the maternal blood group in interest in this case would either be maternal blood group O, because that would lead to a risk of ABO incompatibility, or rhesus negative. You want to look through the book for G6PD deficiency, whether it's normal, whether it's deficient, but bear in mind that this is just a screening test. So even though the G6PD might be normal or stated to be normal, there is also a risk of this to be a false negative. So check with the parents in the maternal side if there is any family history of G6PD deficiency. And next would be birth history. So if the birth was traumatic, there were bruises, if there was a caphohematoma, this would increase the risk of the child being jaundice as well. Go through their feeding, whether breastfed, whether they're bottle fed, how much are they feeding, is it adequate, is there any difficulty in the feeding, how is their bottle hygiene. So this will actually point towards dehydration, which might be a cause for the jaundice. Family history. Any siblings with history of severe jaundice, any history of siblings requiring exchange transfusion. So chances are that they share a lot of similarities in their genetics and they might be more prone to having the same thing as well. Stool and urine color, and presence of any abnormal symptoms. So you want to ask for any temperature instability, whether there's any fever at home, is there any apnea episode at home, is there any abnormal movements at home, all right? Now we move on to physical examination. For every child that comes to you, at every time, weight must be taken, and also the length must be taken and plotted onto the graph. Any weight loss of more than 7% is considered significant. And you may ask, why 7%? When the textbook writes that for a term child, the weight loss might be up to 10% in the first 3 to 5 days. And for prem children, they might actually have a weight loss of 15% within the first week. So why do we take 7%? This is more for safety netting. So at 7%, it's time to make a referral. And a lot of times when you call to the other side, the PEDS MO will just tell you to optimize the feeding, make sure it's adequate, refer to a lactation nurse, and top up feeding and daily weighing, and to see the trend, whether it goes up, whether it's static or it's coming down further. All right, so this is more for safety netting. Assess their hydration status. You want to feel for the anterior fontanelle, whether it's sunken, look at their skin turgor, look at for any sunken eyes, capillary refill time, and also for their pulse volume, all right? Signs of sepsis, organomegaly. So hepatosplenomegaly in a newborn would point towards a diagnosis of inborn error of metabolism, and that's something that we need to watch out for and to be aware of. For any child that has high bilirubin level, anything above the IP, you should look for signs of acute bilirubin encephalopathy. And the easiest way to do that is to do a bind scoring, which we will talk more in depth in the later slides. Is the child pale? Is the child plethoric? Feel for the scalp. lift up the baby, feel the back. Is there any caphal hematoma? So caphal hematoma is a firm scalp swelling that doesn't cross the border, doesn't cross the sutures. SAH, on the other hand, is a subaponeuritic hemorrhage that would give a boggy scalp swelling. And also look out for signs of intrauterine infection. So to put everything in a nutshell, there is this mnemonic, Maggie, for you who are millennials or boomers. Will be very familiar with Maggie, who is from The Simpsons, who is a baby, and who is also jaundice. So M stands for massive organs. That points towards a diagnosis of inborn error of metabolism. A bit dry, so look out for dehydration. Genetic conditions, GI or biliary obstruction, infection, and encephalopathy. All right, so now you've got your serum bilirubin levels. You've done physical examination, you took your history. So it's time to plot this value onto this chart. I think we're all very familiar with this chart. So I've got this from the pediatric protocol. In the CPG, you have the same chart. So how do we use this chart? All right, first you have to determine which column they fall into. Low risk, medium risk, high risk. So two things comes into factor. Whether the child is more than 38 weeks, and bear in mind, again, a note that it's 38 weeks. So I know you take term at 37 weeks, but this is not 37, this is 38, right? And risk factors. Not to confuse risk factors for severe jaundice with these risk factors in this case. So the risk factors in this case are only the isoimmune hemolytic disease, which is your ABO incompatibility, meaning the mother is O. If the mother is B or the mother is A, that doesn't count, right? So only O, or if the mother is rhesus negative. The second one is G6PD deficiency, asphyxia, and also clinical sepsis, not all the presumed sepsis. So based on this, if it's 38 weeks, no risk factor, that will be low risk. If it is less than 38 weeks with risk factor, that will automatically go to high risk. If it's more than 38 weeks with risk factor, it's medium risk. If it's less than 38 weeks and well, it goes to medium risk as well. So you might be asking, what if it's more than 38 weeks and has two risk factor? Let's say mother blood group is O, and also G6PD deficiency. Does two risk factor put him into high risk? No, right? You can have more than one high risk factor, but ultimately it's either risk factors and the gestation. Okay, so you've determined which column this patient falls into. So the next one is to determine which row this patient falls into. So let's say you have a baby who comes into you at 25 hours of life, he's more than 38 weeks, and he is well. So how do you choose? Do you round down to 24 hours with a value of 154, or do you round up to 48 hours with a value of 205? So that's always been the dilemma. So what we would do actually is to count it to the hours. So let's say 25 hours of life. So you take 205 at 48 hours minus 154 at 24 hours, and you divide it into 24 parts. And then 24 plus that one of the divided part will give you the phototherapy level at that level. All right? So when I was a MO, this is what we usually carry in our pockets. So because we have to always calculate to the hour, right? So we siap calculated, and we put it in all these small boxes. So all these things in these small boxes, right, represent 1 hour to make for quick maths lah. So probably that's something that you can do also if you see enough neonatal jaundice cases in your center. Just an idea. So this is the popular question that we always get asked: risk stratification. So you pick up the phone, you call to the PEDS MO. I have a baby who is high risk with this bilirubin level, and they will tell you somehow magically, reduce the risk lah, reduce it to medium risk, or sometimes even reduce it to low risk. So how do they do that? So if we look back at the CPGs and the guidelines, there's actually no mention of risk restratification. But somehow, because of the limitations that we have, we've got limited beds, we've got limited space, we've got limited photo lamps, we've got limited stuffings. So we have to resort to this restratification. But on the pre-hospital side, from ED, from the primary health, what should we do? How can we restratify? So the general rule is not to restratify, right? So don't move the goalposts, but call to consult, and they will give you advices. So coming from the pediatric side, let me tell you why how some people do it, or the rationale behind some of this restratification. And this might differ among centers and regions. So if you've been to a few places, you might realize that they somehow do it differently in different places. So one is the corrected age. So yesterday, you are 37 weeks and 6 days. So that makes you medium risk. You are currently day 2 of life, and your corrected age is now 38 weeks. So they re-stratify you to a lower risk. The next one is ask you to take a baby's blood group, reticulocyte counts, and Coombs. So if mother is O and baby is O, if the reticulocyte count is less than 6.5% and the Coombs is negative, then the risk of ABO incompatibility becomes rather low, and therefore you can re-stratify to a lower risk. And the last one is if the child is more than 72 hours of life. So ABO incompatibility usually occurs early, and if it's more than 72 hours of life and the bilirubin is not really sky high, then ABO incompatibility will be rather, what do you call? Improbable lah. So therefore they will ask you to reduce it to a lower risk group. So you've done all that with Amirul. You've took your history, you've done your examination, and they were unremarkable. He is exclusively breastfed. You plotted him on the charts, and he's thriving. No signs of dehydration, sepsis, hemolysis. And when you plotted him, his TSB is just below the photo level. So comes the next question that the mother will ask you. Doctor, boleh balik ke? And how do we determine? So if they've got no weight loss for more than 7%, no signs of dehydration, bilirubin levels below the threshold, and they are otherwise well, what do? Let them go home. But then come the next question. When should they come back for a repeat? 1 day, 2 days, 3 days? So there's no hard and fast rule for it, but what do I practice for myself? So if the baby is within his first few days of life, or if there is risk factors, or if the trend of the bilirubin is increasing in trend, then I would want them to come back earlier. Maybe I'll give them a TCA of 1 day, come back tomorrow to repeat bilirubin. But if the child is already day 6, day 7, the SB has been a reducing trend, and the child is otherwise well, with no risk factors, maybe I'll give them an appointment in 2 days' time. Or if it's over the weekend, I might even give them an appointment for 3 days' time. But let's say you have a case where a child comes into you at day 10 of life already, no risk factors, coming down TSB, but his TSB is currently still probably 270. It's below the phototherapy level, but you know it's not going to come down anywhere below 85 in the next few days. So what should I do? I'll usually just give them a TCA at day 14 of life to come back to do the prolonged jaundice workup straight away, right? So don't have to repeat so often anymore. But in another scenario where Amirul's TSB is above photo level and he needed admission, so what should I do? So comes the question of when and how should they go to the hospital. So you'll get things like, saya balik rumah, kemas barang dulu boleh ke? Tunggu suami balik lepas maghrib boleh ke? And should I send with an ambulance, or can I send them home on their own transport? So there are two factors here that determine the outcome of those hyperbilirubinemia. Number one is how high the bilirubin level is, and number two is how long the brain has been sitting in this broth of hyperbilirubinemia. So not only how high matters, and how long are they exposed to it also matters. So you want to get them to the hospital to start treatment as fast as you can. But do you have to send everyone with an ambulance? So that would be very taxing to your pre-hospital care counterparts, and they probably cannot cope with that. So how do we choose the patients that we want to send with ambulance? So for me, anything that is approaching ET or above ET needs to be sent with an ambulance. The other case scenario would be if it's above the IP level, the intensive phototherapy level, and they have a high risk of absconding or not going to the hospital or delaying going to the hospital. In those cases, that you might also want to consider sending them over with an ambulance. Otherwise, I think the patients can go by themselves, but you have to advise them to not delay, go to the hospital straight away, all right? So check in the baby to the hospital. You can bring your diapers later, you can bring your wet wipes later, but get treatment fast, all right? So parents might also ask you, do I really need to go to the hospital? So what are the consequences that are attributed to hyperbilirubinemia? So this is called acute bilirubin encephalopathy, to which the long-term effect is what we call kernicterus. So in the post-mortem, you can actually see it on the picture on the right. The basal ganglia is actually really stained yellow because of this bilirubin. So this is like a real case of otak kuning. And this would lead to chorioattitoid cerebral palsy. Chorioattitoid, not spastic cerebral palsy. And patients with high bilirubin levels also will lead to hearing impairment and will need to be screened. So anybody with very high levels of bilirubin, they need to go for an ABR, not the OAE that is used for screening. So if they come to your clinic with high bilirubins in the past, just make sure that they have a screening, hearing assessment date appointment already. And in very bad cases, it might even lead to death. So remember we were talking about the bind score. So anybody with, any babies that come to you with a bilirubin level that is above the IP level should be assessed for acute bilirubin encephalopathy. And the easiest way to do so is to do the bind scoring. So there's three components of it: the mental status, the muscle tone, and the cry pattern. For a normal baby with no signs of ABE, the score should be 0. 1 to 3, it corresponds to a mild ABE, moderate would be 4 to 6, and in advanced ABE, it will be 7 to 9. So it will be very nice if you can include that in your referral letter as well. So how do you treat neonatal jaundice? So the treatment is very easy. Blue light. So it's not UV light. I used to think it was UV light, but UV is actually the bad light, the light that you don't want. So how did they come to a conclusion that blue light is the most effective? For somebody to come up with a conclusion, they must have tested other colors of light as well. And you are right, they actually did. So blue light was found to be the most efficacious, followed by white light, followed by green light. All right? So what happens is that using this blue light, it transforms bilirubin into an isomer that is water soluble that can be passed out without going through the liver for conjugation. So can I use sunlight? That is the common question, to which the answer is yes, surprisingly. But the better question to ask would be, should I use sunlight for phototherapy? So let's look at this research, this paper that was published in Nigeria. So they took 447 infants and divided them into two groups. So half of them received the normal conventional phototherapy, and half of them was put into this semi-dome-like structure with filtered sunlight. So what did they use to filter the UV rays from the sunlight was actually just normal car window tint. And surprisingly, it was as efficacious as phototherapy is. But in 5% of the infants that underwent this treatment had temperatures higher than 38 degrees, there was hypothermia, as opposed to just 1% of those receiving conventional phototherapy. So this is just a very interesting research. Probably not one that you want to share with parents. Parents are very good at putting one and one together. So do I have access to sunlight? Yes, I do. Do I have access to a filter? Yes, I do in my car. So you come out with a conclusion of phototherapy in car, and that's not a very good idea. So direct sunlight, which includes UV radiation, can lead to sunburn. It can lead to hyperthermia, like in the case just now. And instead of reducing your jaundice, it might actually increase the jaundice because the babies lose fluid and they go into hypovolemia. And in the long run, it might even lead to skin malignancies. But I don't want to be admitted. Can I rent a photo lamp at home? So if you can see in the WhatsApp message on the right, package A, package B, very cheap to have it at home. One day, only 120, very affordable, isn't it? But should you really do home phototherapy? So home phototherapy is practiced in other countries. So this is from the CPG in the United States, where there's actually a very strict criteria for those that can go for home phototherapy. And you look at this criteria, almost none of our patients fall into this narrow range. They've got to be more than 38 weeks. They've got to be more than 48 hours. They have no previous phototherapy. And this one, the TSB must only be 17 micromole above the phototherapy treatment threshold. That's a very narrow margin. The LED-based phototherapy must be available immediately, and TSB can be measured daily. So can we do this here? Likely not. So the best advice would be for admission for phototherapy. And another thing is that you might be able to rent the photo lamp at home, but who is keeping track on the photo lamp or how efficacious it is? In our hospitals, we measure the irradiance and we make sure that is sufficient, but who is measuring the irradiance in the photo lamps that you rent at home? So probably not a good idea. So you have managed to convince Amirul's parents for admission, of which they went to the hospital, and you thought that would be the end of it. 2 weeks ahead, you are doing a weekend locum in KK Selayang Baru. Shout out to KK Selayang Baru. And guess who walks through your door? So Amirul walks through your door, and he is currently day 14 of life. He's got his TSB taken yesterday, and it was still 276 millimole per liter, but he is otherwise well. So, prolonged jaundice. Let's talk about prolonged jaundice. All right. So the cutoff point is 14 days for term, 21 days for prem. And our objective in this prolonged jaundice workup is to determine what is the cause of jaundice. Most of the time, more often than not, it is breast milk jaundice. But be reminded that this is a diagnosis of exclusion. So what we need to know and what you need to do is to determine whether it's conjugated or unconjugated hyperbilirubinemia. So conjugated hyperbilirubinemia would be more than 15% of the total bilirubin, or an absolute number where the direct bilirubin is more than 34 micromole per liter. So you want to take note of these essential numbers. So what is your first line investigation for prolonged jaundice? If you can only do one blood investigation, that would be your TSB with direct and indirect bilirubin. So this would be a serum bilirubin because you need the breakdown between conjugated and unconjugated. Cannot be substituted by your capillary or cannot be substituted by your transcutaneous one because it doesn't give you a breakdown. The other first line investigations will be your FBC and reticulocyte count, TFT, and also a urine FEME. I know in some clinics you might not get your results back immediately. Your TFT, your urine FEME might take some time to come back. That's all right as long as you can get your TSB with its breakdown fast. It's okay to review the other results at a little bit later time. All right. So let's talk about conjugated hyperbilirubinemia and its causes. So the most essential one for you to rule out would be obstruction, and that would be biliary atresia or choledochal cyst or anything compressing these biliary ducts from the outside. Second one would be your infection. Is the child septic? Is there a tortuous infection? Could there be a possible UTI? And that's why you send for your urine FEME. The next one would be genetic or metabolic causes. I just want to go astray for a little while to talk about Alagille syndrome. So Alagille syndrome is actually an autosomal dominant genetic disorder. And look it up. Look up the facial features of Alagille syndrome. So very likely that in your life you have probably seen someone with Alagille syndrome, which you did not recognize, and probably the patient themselves also would not have known it, because most of it are asymptomatic, but a very small portion of these people with Alagille syndrome can have paucity of intrahepatic ducts, which will lead to conjugated hyperbilirubinemia, and some of them are associated with pulmonary stenosis also. So you might want to listen for a murmur. So yeah, the babies might not have the very typical features, but I just want to highlight the importance of when you're examining a baby is also good to look at the parents, right? To look out for any genetic abnormality that might be inherited by them. The other causes are alloimmune causes and also idiopathic neonatal hepatitis. So signs of obstructive jaundice, we all know this: tea-colored urine, pale stool, right? So tea-colored urine is something that you have to be careful with when you use this terminology. So in the Western world, when you mention tea, they naturally think of the orange pekoe English breakfast tea, and everybody has the same idea. But in Malaysia, we have a spectrum of tea. So if you're telling a Chinese parents tea-colored urine, they might be thinking of the shitsa in the Chinese shop. Or if you're telling a Punjabi parents tea-colored urine, they might be thinking of chai masala, right? So a better way that I like to phrase it would be dark-colored urine, or some people even say cola-colored urine. Another one is the pale stool. So a lot of times we just naturally throw this out. What is the color of your child's poop? And they will tell you yellow, green, and you take that as normal. So let's look at the stool chart. So this was developed in Taiwan, where they come up with an objective coloring for the stool. And if you look at number 1, number 2, and number 3, so this, if you were to ask the parents, what is the color of the child's poop, they will tell you yellow and green, and they will not be wrong. But this still falls within the pale stool category, all right? So what would be best is that when you're doing a full examination of the child, make it a habit to open the diapers and take a look at the poop color for yourself. And ask the parents if they have any pictures for it. Might sound funny, but a lot of parents actually do take pictures of their child's feces. So just try and ask. So in children with biliary atresia, they are generally well appearing, other than the jaundice. So don't expect to find a very ill child or look for signs of advanced liver disease. So usually when these signs of advanced liver disease come up, the child is already more than 90 days old, and that would be way too late for a surgical procedure, and you've probably missed the boat already. If the child appears ill or is falling off the charts, you want to think about infection or inborn error of metabolism. Let's look at this, quite an old paper in 1991. They compared children with biliary atresia, neonates with biliary atresia, that had surgery done before 60 days of life, had an 80% success rate of becoming jaundice-free. And in those that underwent surgery more than 60 days of life, only 20 to 35% became jaundice-free. And out of these children that are jaundice-free, there's a 15-year survival of 87%. So the take-home message from this is that it really needs early recognition, and the surgery must be done before 6 weeks to have a very good outcome. So detect it early, refer them over early so that all this can be set into motion. These are the second line investigation. So you've done your first line investigation, and you want to zoom into specific diagnosis, and you want to do more investigations to arrive at this diagnosis. So you want to do your serum bilirubin, you want to repeat it again and see the trend of this bilirubin. Your ALT and AST will give you an idea of the hepatocyte injury. And if you have a raised GGT or ALP, that is signs of biliary injury. So if you have a patient with raised GGT and pale stool, that is very suggestive of an obstructive cause of jaundice and needs to be referred immediately. So your GGT to be significant usually is in the range of hundreds. The function of your liver is to produce albumin, and is also used to produce clotting factors. So you want to measure the albumin, you want to measure the coagulation profile, and if your albumin is low, coagulation profile is deranged, that reflects your synthetic function of the liver. If the child has metabolic acidosis, your RP is deranged, you have hyper or hypoglycemia, you want to think of metabolic diseases. FBC can give you a hint if it's an infection. And for patients that you suspect an obstructive cause or biliary atresia, an ultrasound abdomen will show absent gallbladder sign or triangular cord sign. So again, if you are suspecting biliary atresia, don't order the ultrasound abdomen, wait for the results and see what the report is and then refer after that. You want to refer them fast so that Pete Surgical can order the ultrasound abdomen, expedite it, and if they warrant surgery, can be done early, all right? So don't sit on it. For those with unconjugated hyperbilirubinemia, it's either an increased production of hemolysis or decreased clearance. So anything that can increase the manufacturing of red blood cells or increase the hemolysis will essentially lead to jaundice. It can be caused by sepsis or increased RBC breakdown. And these are the causes of decreased clearance of bilirubin. So you have done your examination, you have ruled out all these other causes. It's unconjugated bilirubinemia. The child is well, the child is feeding well, the weight is increasing, stools are pigmented, then you can come to a conclusion of breast milk jaundice. All right, so now that you have made a diagnosis of breast milk jaundice, how long should you follow this child up and when can you discharge this patient? So they come at day 14 of life for a term baby, you've done all your examination, you've done your blood investigation, it's unconjugated, you've come up with a diagnosis of breast milk jaundice. Do I need to repeat this bilirubin level until it comes down to a certain level? No, you don't have to. So when you've come to a conclusion of breast milk jaundice, you can safely discharge these patients, give warning signs to the parents, tell them what to look out for, and you can review them at 1 and 2 months old during their immunization appointments. And so that's it. We are done with our webinar. So in conclusion, you want to differentiate your pathological, physiological, and prolonged jaundice. You want to exclude obstructive causes. Don't re-stratify. Call to consult. Recognize signs of acute bilirubin encephalopathy. And if you come to the conclusion that this patient has breast milk jaundice, you can discharge these patients if they are well. And these are my references. And with that, let's listen to any questions that you might have. And don't forget to subscribe, like, and share our video. Thank you. Back to you,
You completely
Kieran.
beat me. You completely beat me to it, buddy. Thank you, everyone. A lot of questions from everyone today. Very excited, and I'm so glad you gave yourself 5 stars because I would have given you 5 stars as well. Excellent. All right, so I'm just gonna kind of put up. I've got a bunch of questions here. If anyone's got more questions, we'll kind of read through the chat in a little bit. But what I'm going to do is I'm just going to bring up some things here that we've kind of put up in a little PowerPoint, so it makes it easier for us. Window, webinar questions, share. All right. I wonder if you guys can see this. No, not yet. Doesn't want to. Doesn't like me. This is slides. All right.
All right.
Brilliant.
Yes.
Brilliant.
Is there any
Absolutely
role
brilliant.
of monitoring
Hold on, Chris.
TSB?
Oh,
Oops.
sorry, Chris. Did I get rid
It's
of that?
okay.
Okay. It's just me, clumsy hands. Up, and I will put that in full screen for you, and I will read out the questions for you. Wait, there we go. All right, sorry. Let me go to the front. Complete amateur me. All right, look, guys, we've got a bunch of audio questions for you, and we're gonna ask them. So, first question is, let me see. Let me pull this back. All right. First question for Chris is, what information do I need before I pick up and refer the case to pediatrics medical officer or to ED?
All right. So, yeah, you need to do a thorough physical examination, a thorough history. But in essence, actually, when you call and pick up the phone, they want to know very little information, only the salient points, right? So let me make a referral for you, lah. All right. So, kring kring, hello. Uh,
Oh, hello. Hi, Chris.
Hi. Yes, I'm Dr. Denise from KK Selayang Baru. I would like to refer a patient with neonatal jaundice.
Sure,
So
go ahead,
I've got
buddy.
Amiro, who is currently day 4 of life. He was born term at 38 weeks, perinatally uncomplicated. TSB today is above the photo level. It is 270. That's 10 above the photo level. I'm taking low risk. He's got no risk factors. Maternal blood group is B positive, and his G6PD is normal. I'll be sending him over to you by their own transport. ETA is 15 minutes, and he will probably need phototherapy. Thank you.
That's really simple, isn't it? I think just getting the basic salient points, not very difficult at all. And people should just kind of accept that. That's really, really, really very easy. Thank you, Chris. We'll ask the next question. Which patients do I have to send to the ED in an ambulance, and which can I ask to walk in?
All right, yeah. So, which patients should I use the ambulance? So, those that are approaching ET level or above ET level, and also consider patients above the IP level that might have risks of absconding or delaying transfer there, lah. Right? So, the others, I think, with good instructions, can be sent on their own.
Okay. Too easy. All right. Hi, doctor. May I know if I should be concerned with the ratio of conjugated to unconjugated bilirubin if the total of serum bilirubin itself is less than 85?
Okay. So for a child to be to have conjugated hyperbilirubinemia, there's two what do you call? Two factors lah. So the one that we are very familiar with is the 15%, right? So what happens when the total bilirubin fall to a level that is very low, and then let's say the serum bilirubin is 60, and the conjugated is 30. Oh, that's like 50%. So that is when you use the absolute value lah. So if anything less than 34, we don't consider it as a conjugated hyperbilirubinemia.
All right. So just kind of looking at the levels themselves and then kind of deciding whether or not you need to be concerned. All right. Fair enough. Okay. Next question. Good evening, doctors. Oh, thank you. Is G6PD intermediate considered a risk factor for jaundice? Thanks.
Yeah, so I would usually consider those G6PD intermediate as G6PD deficient lah. So what happens, right, is G6PD test that is documented in the book is actually a screening test. So what they do is that they put blood on the filter paper, put some reagent on it, and someone actually puts it under some light and looks at the color. If it turns out to be this color, it is G6PD normal. If it turns out to be this color, is G6PD deficient. But colors are a spectrum, right? So you're actually depending on what the person sees. And if the person is not very sure whether it's this color or this color, it's somewhere in the middle, and that's when they commit to G6PD intermediate. So it's better to err towards over-treating than under-treating, and I will take these patients G6PD intermediate as a risk factor lah.
Okay, great answer. Absolutely great answer. All right, next question. If I don't have a method to measure jaundice objectively, clinically child is well and jaundice is until chest, can I discharge the patient home and ask parents to go to the nearest clinic for review tomorrow?
Very
Sounds
good
like someone
question.
has
Yeah. So again, the Kramer's method, you rely solely on your eye power. So go back to the research that the paper that we were talking. So your Kramer's rule is very good in identifying jaundice, but it's not very good in correlating it with the serum bilirubin. So if the child appears jaundice, that is indication enough to get an objective measurement of the jaundice. So don't send them home. Send them to the clinic for assessment.
Right. So don't send them home. Send them off to clinic. And when we are talking about clinic, we're talking about KK. Are we talking about ED? What are we talking about here?
Yeah, EDs are for emergency lah, and this surely does not warrant an emergency. So the clinic would be the best option. There are some pediatric centers, private pediatric clinics also with transcutaneous bilirubinometer or capillary bilirubin. You can go to that also. That can be a viable option as well.
Huh. Great, excellent. Okay. No, if I have a child with jaundice who requires phototherapy, parents are adamant that jaundice is self-limiting and wishes to go home. Are there home remedies, and what about home phototherapy?
Yeah. So home phototherapy is not a very good option in Malaysia. It is available, but it is not available through legal means lah. So just because you have a photo lamp doesn't mean it's efficacious. The photo lamp needs its irradiance measured, and it has to be in a particular range to be effective. So if the patients bring the child home and put on phototherapy, that might be just false reassurance to the parents. So the best way is to get it treated fast, and once they are well, they can go back home lah. There's no home remedies that I know of lah.
All right, so you wouldn't really recommend home phototherapy. You'd be more concerned about like the monitoring and stuff like that, wouldn't you?
Yeah.
Great. All right. In the KK setting, when should I refer a baby with hyperbilirubinemia for further assessment? I think we kind of answered this question already, but Chris, why don't you give it a go?
Yeah, refer a baby for further assessment. It shouldn't be further assessment lah. The assessment should has already been done, and you are actually referring them for therapy lah. So if they are above the level or if they got worrying signs, you send them over for intervention. So either phototherapy, or if they are losing weight, then you want to get that addressed in the inpatient setting.
Right. Chris, someone wants to know, I think we've already answered this as well previously in your slides, but does putting a baby under natural sunlight help reduce jaundice levels?
To a certain extent, yes, but it should not be advocated lah, because the ill effect is small, and there are much easier and more available options lah, which is phototherapy.
Right, yeah, and very safe as well in a monitored situation, yeah. All right, if the baby was originally a medium risk because of 37 weeks and 5 days, and upon review is day 4 of life, hence it's technically 38 weeks and 2 days. Someone was very technical in this question. Can we upgrade to low risk for the photo level? So a kind of change in the risk factor right there.
So more of a downgrade than an upgrade lah. Yeah, so the rule of thumb is don't shift your goalposts. If the baby is medium risk, take medium risk. You might call and consult, and because of limitations of our setting, they might re-stratify it for you, but let them do it. We don't do it from our side.
Yeah, I think that's a good plan. All right. I think a very concerned mother wants to know, when will the jaundice go away?
If I'm assuming that this is a breast milk jaundice lah, and it can be quite a worrying factor for parents. So they want to know an objective answer. When will this jaundice go away? The answer is nobody knows, but it will go away. So that's something that you just have to reassure them that just because they are jaundice, it's not dangerous. There's no ill effect to the child. It's physiological, and it will clear when the child matures.
Great. Right. Is there a way to estimate how quick the bilirubin can increase? What do you think about that, buddy? Like, is there a way like you can kind of tell like the bilirubin is going to go up a little 20, 30, 40? Is there a way to do that, or?
No, that's why it's not just a one value kind of thing. It's more of monitoring the trend lah. So if it increases too fast, that's not good as well. You might want to monitor a little bit closer. Yeah, but there's no way of telling exactly how the trajectory will be like.
Sure, good answer. Yeah, will exchange transfusion change my baby's blood group? Now, that is quite the question. I wonder who asked that question. Will exchange transfusion change my baby's blood group?
No lah, it will not change. Usually we match it to the type appropriate blood lah. Uh, just just something interesting is that exchange transfusion you use whole
Mhm.
blood lah rather than packed cells, but it will not change your
Right.
baby blood group.
Right. And why
Uh,
do we use whole blood instead of packed cells?
that will be way too much hematocrit
Yeah.
to infuse to a child. Yeah, because
So you're just exchanging the entire
you're
body. Yeah.
exchanging the baby's blood for somebody else's blood lah, which has a lower bilirubin level.
Yeah. Fair enough. Okay. Can I tell parents to bring baby for car light therapy? Maybe in mild jaundice. I'm guessing that they want to put the baby in the car. Now that
Yeah.
JPJ is all happy with window tinting and all, so maybe put the baby in the car, get better, no need to come to hospital. What do you think?
No lah, don't leave the baby in the car just for phototherapy. But if you want to find a reason to put the baby in a car seat and go for a joyride,
Mm-hmm.
yeah, you probably can use that as an excuse. How effective it will be, I'm not very sure.
Sure. Sure. Excellent. Okay. When it comes to monitoring the levels, is there a range to refer to as to say how much it should be reduced per day?
How much should it reduce per day lah? As long
Per
as
day.
it's below
Yeah.
the threshold levels, I think that's okay. Yeah. There's
Yeah.
no arbitrary number.
I think that's about right. Yeah. So as long as it's just below the levels and it's getting there, then you should be fine. All right. Hi, doctor. How to differentiate between breast milk jaundice and breastfeeding jaundice?
All right. So even though both sounds very similar, but they're actually very different thing. So breast milk jaundice is physiological jaundice. Breastfeeding jaundice, on the other hand, is just another name for dehydration. So these patients are not getting enough fluid, and hence that's why they are jaundice. So very different things.
Okay, so a lot of history taking and kind of deciding between there, right? Okay, next one. Can I put the baby in front of a laptop or computer or oh, come on, guys. Can I put the baby in front of a laptop or computer or tablet since it also emits blue light?
Very
I'm praying
creative.
I'm praying this is a joke question, but Chris, take it
I don't
away.
know, but probably I don't know if you can get permission to do a research on it, but it will be very interesting.
I'm smelling a BMJ Christmas article out of this one. Yeah, we never know, right? I don't know how we're going to get past NMRR, but yeah, well. Okay, is there a role for monitoring TSB in a baby with prolonged unconjugated hyperbilirubinemia?
For prolonged jaundice, no lah.
Mm,
If you have made a diagnosis of breast milk jaundice, then don't need to monitor lah. This will just add more stress to already stressed up parents lah. So just assure them that it will go away. It might take some time, but don't keep monitoring it lah, right?
yeah.
Yeah.
I probably just had a lot of stressor in there. Yeah. All right. I think that's the questions we have, but I've got more for you, Chris, because everyone wants more of you. I'm just going to read them up. Let me just put this up in full screen so that. All right. So, someone wants to know, hi doctor, when a baby's TSB is normal in the first week of life, need to repeat in second week? Question. Secondly, can obstructive jaundice present later in life? Example, after 3 weeks. I think we'll break that down a bit. So the baby's TSB is normal in the first week of life. Do they need to repeat it in the second week? Is the question. That's the first question.
No lah, don't need to repeat anymore. If it's okay already and you discharge the patient, you don't have to give another TCA just to repeat. Anyway,
Right.
for a patient that has never been on phototherapy before, you can actually go visually. If the patient doesn't appear to be jaundiced, then highly likely they won't be
Right.
biochemically.
Okay.
Yeah.
Biochemically. So, yeah, all right. So let me just my bearings. Okay, at what day of life do we stop phototherapy for babies which has a serum bilirubin less than photo level? So at what day of life do we stop phototherapy for a baby who has a serum bilirubin level less than photo level?
If it's below photo level, then yeah, you stop it straight away lah. Right?
Yeah,
Yeah,
no
there's no
reason to
indication
keep it
for
going,
it
right?
already.
Yeah.
So you terminate the therapy.
Yeah. And how long would you monitor these kids though after you stop phototherapy? Like, do they need like something recurrently happening for them? Like, do they need
Once you
follow up
stop the
after
photo,
that?
once you stop the phototherapy, there's a risk of a rebound jaundice. So usually we ask
Right.
them to go to the clinic the next day to just get a level to make sure that it doesn't rebound.
Right. Okay. Sounds good. Let me see. How frequent do we need to monitor bilirubin in prolonged jaundice? In my clinic, we refer patients. No, we refer to PEDS clinic, and patient will be reviewed after 2 weeks. So, how long do you need to monitor bilirubin in prolonged jaundice? Was the question.
Um, if you have already done your prolonged jaundice workup and everything comes back to be normal, then you don't have to monitor them anymore. So that it was likely going to be breast milk jaundice. No monitoring is required.
Okay. Is there a reference range for GGT? There are some GPs that check GGT as part of their prolonged jaundice workup.
I cannot remember offhand
Sure.
the
Yeah. Yeah.
values
I
lah.
don't think I
But
remember. I don't think I
theoretically,
remember
if
too.
it's
Yeah.
in the hundreds, then that is not normal already.
Okay, sure. Yeah, and the next question is also related to GGT. If the GGT was 200 at day 14 of life, when repeated at day 4040 has been reduced to 100 plus, is it okay to monitor further or must be referred to pediatrics as even though all the other liver enzymes are normal? So just isolated GGT elevation at day 14 of life, repeated at day 40 has reduced to 100. So it's down going the GGT.
All
Do we
right.
still need to refer to pediatrics?
So GGT cannot be taken in isolation. So
Hmm.
GGT just gives you an idea that there might be an obstruction to the bowel flow. So this can be brought
Hmm.
about by many different things, not just biliary atresia or um, or choledochal cyst. So things like neonatal
Right.
hepatitis could also lead to an obstruction that might also lead to a raise in GGTs lah. So don't take it in isolation. Look at the patient in a whole. Tie it with other
Mm-hmm.
factors. Is there pale stools? Is the child growing well?
Right.
How is the color of the urine? Yep.
Mm-hmm.
So take it in
Okay.
entirety.
So just look at the whole patient, right?
Hmm.
Holistically. Okay, someone wants to know what retic levels do you consider jaundice secondary to hemolysis? Another levels question. What
Okay.
retic levels?
So the cutoff point that we take for reticulocyte count is 6.5% lah. But that differs from center to center also. I've also been to centers which take cutoff of 6. So go with your local protocol.
Okay, good answer. Is there more than a 50% increment in total serum bilirubin level? Do I need to exclude sepsis straight away? So the thing about increase about 50 in TSP, are you concerned about sepsis or not?
It should be one of your differential diagnosis at the back of your mind. It's things that you need to exclude lah, and not just the sepsis, but the whole lot of it. Is it IEM? Is it an obstructive cause? Is there hemolysis that's ongoing? So all this has to be at the back of your mind while you're examining and you're seeing the child.
Okay, all right. Chris, last two questions. Is phototherapy still required if the TSB is above photo level at day 14 of life? The day 14 of
Usually we
life,
don't lah.
TSB.
Right.
Mm,
So theoretically, your blood-brain barrier has already developed at that point of time, and very unlikely for the child's serum bilirubin to still be above the photo level by day 14 of life. Generally, we don't, but we will closely monitor, and we need to look out for other signs that might cause the jaundice as well. That would be more important.
right. Chris, last question on the board here, unless someone adds someone new. It says, good evening, doctor. And this sounds like a question that maybe this person's experienced. If the baby is clinically jaundiced up to the thigh, right, because we know it spreads from above to below, but the bilirubin level is below photo level, is it okay to admit the child for phototherapy? So that means the bilirubin level is normal, but the child is jaundiced. So
All
would you
right.
still admit for phototherapy?
uh, the,
Tricky,
yeah,
tricky.
something must be wrong lah. So it's either your serum bilirubin is wrong or your eye assessment is wrong lah. But that being said, let me just share one interesting case that I had in the past. So we had a baby come in to us that was jaundice like the Simpsons, from head to toe to palm to soles. Everything was jaundice. And when we took a serum bilirubin, lo and behold, it was below the phototherapy level. surprise, surprise, we asked the parents, why is he so yellow? They had the brilliant idea that smearing kunyit all over this baby would bring down the child's bilirubin level. So, yeah, just a funny story to share. Thank you. I can't really hear you, Kiran.
Sorry, Chris. Sorry. Oh, sorry. No, I
No
was talking
problem.
to myself there again. All right. So, a good evening, doctor. A baby has been discharged from the hospital for prolonged jaundice with transaminitis, which already reducing in trend. If it increases again, is it warrant to refer immediately?
Yeah, if there is a sudden spike in the liver enzymes in a previously reducing liver enzyme trend, yeah, it is
Yeah.
yeah, a reason enough to refer back. It need to be investigated further.
Great. Chris, absolute last one. Good evening, doctor. Do all children with prolonged jaundice, LFT deranged, need a referral to ED? Child is well, not jaundiced. What do you think? Like kid's jaundiced, kid's not jaundiced, looks well, but has got just prolonged jaundice level, but clinically looks
Okay.
well.
So what I understand is just a slight increment in the liver enzymes lah. Can you monitor or do you need to refer? So if the liver enzymes is way off the chart, very high, then no doubt just refer. But if it's just slightly above the normal for that, and it's not too high, then well, you can give an appointment just to repeat it and to see the general trend of the liver enzyme. If it's coming down, then you're more assured. If it's going up trend, any worrying signs, just refer.
Okay, great, Chris. Chris, thank you very much. It's been an absolute wonderful pleasure to listen to you present today.
Likewise.
Thank you
Thank
very
you
much,
all
buddy.
for coming.
Okay, so
Thanks.
thank you very much, everyone. That'll be all for today. Please like and subscribe. I know we've all become YouTubers suddenly, but like and subscribe. And then if you've got any more podcasts, any more webinars, this will be right up here on YouTube again. Thank you very much, everyone. Hope to see you guys
Thank you so
soon.
much,
Okay?
guys.
Bye bye.
Bye bye.